Happy Baby Friday and welcome to our latest edition of Healthcare Happenings, where I am pleased to have my friend and colleague Shelly Asbury with me from Neghan Healthcare Resources. Hey, Shelly.
Hey, Betty, how are you today?
I'm good.
Good.
And we are going to be talking about ASCs today, ambulatory surgical centers. For the latest broadcast, I've been trying to find, like I had Tanya, my friend Tanya, on last time about anesthesia. So picking things that maybe aren't as well like seen out there and talked about and stuff, but are big. ASCs are growing and growing and growing. So I asked my friend Shelly if she would come on, and she graciously agreed. So I'm glad that she could make it today to join us out here. And Shelly has more than 40 years or 40 years, sorry, in the industry. So she's got a few more years than I do, actually. And she is into billing, coding, compliance, education, right? Practice management, revenue cycle management, and of course, ASCs. In fact, there was a project that she and I were putting together to work with an ASC. So she really knows her stuff. So if you have questions as we are talking today about ASCs, please just go ahead and throw them in the chat, and we will see if we can get them answered for you today. Now, Shelly also has worked on committees, different committees with AAPC, AHIMA, FCSO, Florida Coast, is one of our MACs down here, NGS, which is another MAC, and with CMS. So before we get to talking about some of these other things, I wanted to ask you about that, Shelly, the committee stuff with the MACs and with CMS. What kind of stuff were you doing for them?
So for the CMS back in the day, of course, it's been a few years ago, but I was on their advisory and outreach provider panel for the education. So basically that kind of went from there. And I sat, back in the day, for those of us that have been in the healthcare arena for a while, you remember like Trailblazers and all of that good stuff. I sat on their, they called them POEGs. Their provider outreach and education groups. So we, met quarterly, if you will, and try to devise plans to roll out education sessions through the MACs for those specific areas. So it was very interesting. Cool. I spent quite a few years, yes, and the recent one, like I said, I just came off of the First Coast service options, so I'm kind of taking a little bit of break with the CMS and the MAC outreach and provider education sessions, and kind of focusing more now with doing some education and advocacy within my community at this time.
Wow, that really sounds neat. And if people are interested in serving like that for outreach, because I think that's a way, kind of like on the inside, you can help with provider education and getting the word out. Is that something that they came to you about, or is it something that you've seen posted for, CMS or the MACs, or was it something like that once you did one, then, everybody else is like asking you to do it too?
I had originally started out the CMS one. I was actually asked to be on that panel. I had a contact many years ago within the CMS arena in the coding and billing, provider outreach, education area, and she has since long retired, but she reached out to me and asked me if I would be interested in serving on that panel along with her. And then from there, I just I do a lot of, of course, auditing and compliance education and coding and billing. So I spend a lot of time, reading the MAC guidelines and rules and regulations. And I really pay attention to the education material that they put out. And they you can find it on their websites. If you go into their provider outreach and education area, they'll sometimes have a call, if you will, for new volunteers, because you serve, a term, if you will, and then you roll off. So you just have to be cognizant and pay attention, and you go on there and click on the link, if you will, and there's an application process you go through, and then you're either selected or you're not. So I spent quite a few years on multiple MACs, and it was a very good experience. And I learned, quite a bit about, how they process and how they provide their, education and outreach, and how they come up with topics. And so it was a good experience. So, I would say that anybody that's definitely interested, reach out and fill out an application, and, give back to your community, give back to the, associations, and serve on those committees.
And I think it's a good way also for you to be able to help your clients, by sitting on those, because then you kind of are understanding more of, what's going on in the MAC, and, their viewpoints and how they're putting out stuff. And it can help you in with dealing with your own clients to say, well, the MACs are taking this kind of stance on this, or, kind of thing. So I think that's really cool. So thanks for putting out that information. And I see our friend Sonal is here. So Sonal Patel is joining us. She says hello. She's excited for the conversation on ASCs. So it's good to see you, Sonal. Glad you're joining us. And we have Molly out there saying good morning to everybody. So good morning, Molly.
Good morning.
As people come in, y'all just go ahead and throw a little shout out in the comments to let us know where you're watching us from, so we can make some little comments back to you. Shelly and I are both in Florida, so we're both in the warmer weather.
No snow.
Although I hear, except for the upper East Coast, boy, they got kind of slammed this week. Mm-hmm. So, but everybody else is getting somewhat mild, I think, this winter. It hasn't been too bad on people. So back to our conversation on ASCs. Before we get into that and talk about some specifics, I just wanted to have people that are listening and attending now and later, get a little bit more information on you. Now, I've known you for a while, but I always like to do, just a little interview segment with people so that everybody can kind of get your background a little better, and it may help them, spur them to ask a different question, So, we got somebody from Seattle in there. Hey, Holly, how you doing? So you've been in healthcare, I said, 40 years. So how, and you cover a lot of stuff. You're kind of like me. I got in and I've worked in places where I had 450 different physicians from every specialty known to man. So I got exposed to lots of stuff instead of saying, I've worked in, one specialty for 40 years, which I'm not saying is bad. I'm just saying, when you start, I'm glad I was in the kind of situations I was in, because I can do some of everything and things like that. So with your kind of expansion on your side, what's your kind of journey in, where you started and how you got to what you're doing today?
It's been a very interesting journey, and I can kind of say it's actually coming back full circle here recently, if you will. But, one thing, it was funny, Betty, when, we were talking about my bio, I just realized, when you're writing it out and things, it doesn't sound, that well, if you will. But now I think about it, it's like you said it out loud. It's like 40 years, I've been in this business, and it's like, oh my goodness, it's been a long time. Definitely a lot of changes, a lot of good, a lot of bad, but a lot. So I originally had started my healthcare journey, if you will, my healthcare career. I actually also have a clinical background. I was a midwife back in the day. So, and I, delivered multiple babies and worked in, we have a local birthing center here, and I actually worked in the birthing center. That's how I got my start. And then, my family and all their friends, of course, said, well, she works in the healthcare field. We'll start asking her healthcare questions, bring her medical bills and look at our medical bills. We don't think we got charged correctly. So I started really paying attention and started focusing my efforts on that side, if you will. So I kind of decided, oh, I kind of like this a little bit more than the clinical side. And so I went back to school and went and got my health information degree and got some coding certifications underneath me. And then, of course, it was very hard to get a job. It's still kind of sort of that way now if you don't have the experience. And it's like, well, if you don't give me the experience, how am I going to get a job? So we had a little community hospital in my area, and I begged and begged and begged, and I got hired as a file clerk in the department and actually worked my way up through the department. Ended up becoming the health information management director and the chief privacy officer for the facility. And as the years progressed, I got promoted to our corporate office, which was in the Nashville, Tennessee area, and went back to school because they were moving me into a compliance job, if you will, more duties on the compliance side. So I became certified in compliance, and then I became the national director of healthcare compliance for an entity that we owned hospitals in 26 states, and we started buying physician practices. So and ASCs. So I was responsible for all of the hospital compliance, coding, billing functions, as well as the revenue cycle side of the house. So I garnered a wealth of knowledge with them and was with them for almost 15 years until they sold their company. And I became, getting into the consulting side, if you will, utilizing skills where I've been needed: coding audits, compliance plans, programs, revenue cycle assessments. And so again, I've been approached with, medical billing issues from friends, family, colleagues, if you will. So I've kind of focused and shifted a little bit more so, and I've brought back that patient advocacy side. So I'm kind of focusing more so on the patient advocacy area, helping, with denied medical claims, understanding their, medical policies, making sure they're getting the right policies, if you will. And I do still work in the coding compliance arena. I do still help, ASCs figure out their billing situations, if you will, provider-based, services. So it's been a full circle.
Yeah, you've done quite a lot. That's
Yeah,
good.
yeah.
I always think, and I think it was for us old timers, it was a little bit easier because I had a clinical background. I was an X-ray tech, and then kind of got pushed into what I was doing because I didn't want to do that anymore. And so I think, back then it was easier to get that foot in the door kind of position, it seems, than maybe today. So, and start to get moving around when you talk. That's why I like talking with those of us, ladies and gentlemen, that are, the old timers, because we have a lot of good, track record kind of stories about everybody's journey is so different. And a lot of us, because back then we really didn't have positions either for what we do now. I mean, they didn't really have healthcare consultants for revenue cycle and coding and billing. And they didn't even have, they didn't call them, coding professionals back then. They always would have some other name, and the coding stuff was just kind of thrown in with it, So that's one of the reasons why I like getting everybody's stories when they come on, because it's always so interesting how, most of us older ones in here, it's just like kind of either we fell into it, we were pushed into it, we were doing something else, and somebody said, hey, you pick this up too. And it was kind of like a side thought to practices and facilities back then. And then to see how it's gone today, to where still some of them don't quite get yet, I don't think, how tight it is to finances, but most of them now are understanding the importance of, the jobs that the professional coders and billers and, those people are doing in these practices to keep them viable. So I always just find that really neat to kind of, walk through that with people. And Sonal made a good comment here about you. I just wanted to share it that she said she loved hearing about your patient advocacy work. And that's why I said I was going to ask you about it, because I just thought it was very interesting when I saw that, that it's really necessary. And thanks for continuing to make a difference.
It is. And it's been very interesting. And, I just worked on a big case where this individual had to have emergency open heart surgery, and they were hit with a $325,000, out of pocket bill, if you will. And they were fighting with their insurance, not wanting to, take care of it, if you will. So I worked on that for probably about almost 2 months, and we finally made some headway. So I feel really good about that one. So that was interesting. Yeah.
It's always good when you get those wins, and you like to kind of highlight them and push them out there. So as far as the ASCs go, so you were doing multiple things for the company that you were with. It got bigger and bigger, and ASCs kind of came into part of your coverage, part of your line under your purview. So you started to dig into that. So what is it about ASCs, that you kind of took a shine to?
I think I kind of, and don't take this the wrong way, but sometimes I think they're considered like the stepchildren of the facility services and the service lines, if you will. They're kind of put on the back burner, and there's not a lot of education provided to them. There's not a lot of guidance. I was doing some research, when I was kind of delving into putting some education sessions together for some ASCs. And it's very interesting because they did this study, and it's like only 76 to 78% of ASCs even update their coding and or billing guidelines. They don't know, and you walk into a facility and you may ask them, well, show me your coding materials, and they don't even know what a CPT book is or a coding book. And so it's been very interesting to do some education with them and just give them the guidelines. And it's very interesting because, ASC billing and coding, if you will, is definitely a different animal than, provider practice billing or even hospital side billing, hospitals, DRGs, and, providers, E&M services, fee for service. And ASC has some specific billing rules where you can't separate certain things. And depending on what the surgical procedure is, the device may be included in the procedure code, and you don't code separately for that device. And I have found, through my years, if you will, in reviewing ASC services, a lot of them separate them out, and they bill those separate devices separately. And then they get those lovely letters, from the CMS or, a private payer, if you will, wanting to audit their records, and they don't understand why they're being asked for all this money back. So it's been a journey.
Yeah. Well, yeah. And that's what, when I got you in to help me with that one ASC that we were helping, you really do have to think differently when you're looking at it. And when I would talk to them, because it was owned by a couple physician group. And so when I would talk to them about different things, I'm like, okay, now who are you? What hat are you asking me about? Are you talking about what the physician practice bills on the pro fee side? Or are you talking about the ASC itself? Because they're not going to match. And I think of it like when you look at the facility ED versus the pro fee ED, and people are like, well, this one's a 4. So that I said, well, it doesn't always work that way. Just because on the pro fee side, it's one level, that has nothing to do with how the facility bills for the ED. They're looking at resources. So you really have to think of things in compartmentalized ways when you're looking at ASC stuff, and make sure you're thinking about the ASC specific when you're doing their stuff, and kind of separate the pro fee, the physician side, kind of out of it.
Exactly. And also what's really interesting, about the ASCs also, remember, this is kind of multi-specialty. It's not one set specialty. And also they already have an established diagnosis, from the provider. So they're not, doing that plan, if you will, doing that medical decision-making to choose the diagnosis or make sure that their services, fit. the requirement is for the patient to be able to have that ASC procedure, they must already have an established diagnosis and the procedure, ticked and tied together, if you will, before they even walk in the door.
Yeah, yeah. Now, to get into the ASC stuff, we got, I just want to point out John, hey, John, the coding cheerleader, John Piaskowski is with us today. And he says that he's never coded for this type of facility. So he's sure he will have a lot of questions, and we'll try to get to, what you have and try to see if we can answer some for you today. But good to have you with us, John. And Sonal made a comment about talking about how we're billing with the ASCs, and she'd asked that that there wasn't any unbundling in the ASCs, making a joke.
Yeah, there's a lot, unfortunately, again, it goes back to that education piece. Sometimes you'll get these, and I'm not picking on physicians because it happens with, hospital entities as well, other organizations. They'll get, a wild hair and say, oh, I'm going to start this ASC and we're just going to start billing all these codes. And, they don't pay attention to the coding guidelines and or rules. And they just think they can, oh, yeah, we can bill C codes with our pacemaker implants or what have you. And unfortunately, that's not the case. It's definitely an unbundling situation. They get a lot more money than they should.
Yes. Yeah. Well, and the thing is, I always tell people that you might get it, but it doesn't mean you get to keep it.
Exactly.
So, yeah, it's all real and fun, at the time. But then when you start getting those letters, it's like not so much. And as far as regulations and guidelines, I know I had asked you to kind of send me some links that we could share with people today. So if people are looking at trying to get more education, by listening to our discussion, they're interested in it, or it's something they've been interested in but just didn't know how to find stuff. I think sometimes you can Google something and you can get a slew of things, but you have no idea what's good, what's not good information, because then you've got Wikipedia, who just throws Lord knows what out, and you've got AI. Sometimes it's like hallucinating and making stuff up when you're reading it. So you can't always count on the AI stuff either. But some valid, good, solid resources, if people are looking into, or if they're working in an ASC and are just like, I just don't know if we're supposed to be doing this, if we're not. One of the main places would be in, the Federal Register, right, is where you can get a lot of information. So Shelly shared with us the Federal Register where it has the OPPS and the ASC payment system. So that link is up, and I'll make sure we copy and paste it into the chat for people so that you can also go in there and take a look at it later, because this is a whole lot to try to write down to go back in and look.
I know, right?
But this is where you're going to find some of the information that the government has put out. And then we also have Title 42 in the scope of the ASC services by the government. So that is also another good place where they can get some information for what you can and can't do in ASCs, because that's something I want to get into with you in just a minute, but I wanted to put our resources out here. And then, of course, CMS. CMS has an ASC center. So if you go to CMS, you can go and look, and they have where they try to put everything together for you, and where you can go and research things that, from previous years, how things have changed or updated or whatever. So you can get a lot of good information on ASCs on CMS. As far as your commercial payors, Shelly, do you find, just like with other things, that for when it comes to ASCs, they kind of follow Medicare and then make all their own little weird things?
Yep. They have little nuances that are specific to their payer policies, definitely.
Do they make them easy to find on their websites?
In my experience, and the ones that I have worked with, I find that it is pretty user friendly. You may have to, kind of click through a couple things, but I don't feel like they're trying to make it ambiguous and or hide certain things like some of the websites we utilize in our profession. It's like, really, you tell people they got to follow these rules and then you can't even find the rules. So
yes, yeah.
or they tell you, see rule number 1. Well, I'm reading rule number 1 and it says see website,
They have gotten better than, years ago when, there was just nothing out there.
Yeah.
So at least it seems that most of the payors are making attempts at getting the information out. And I think some of that, and it might be my cynical side, but some of it might be, they're telling people that they're going to hold them to these rules, but they won't tell them what the rules are. Like the old days when we had what they called the black box edits, when they would have these edits that they would deny payments. And then when you would try to ask them why, they would tell you that they didn't have to tell you that, it was a black box edit, it was, a secret. And those kind of, we went through to where, of course, places started suing and things like this over, you can't tell us no and not tell us why that it's a secret. That's just silly. And so with the start of that kind of things, with the pushback, now they're getting better and better at putting information out there. And yes, I agree. Some of them still bury it in weird places just so they say, oh, well, it's on the site. But other places they're really good about trying to engage, and they have provider education units that work at the payor that, get word out. The Macs have gotten a lot better at putting information out for us. So I think it's improving. We still do have a couple ones that are, a little buggerish about it, but for the most part, they're getting better. So that's good to know. So if you're doing commercial patients in the ASC, you want to make sure that you're going to those commercial payors, at least your main ones, I would say, is usually what I tell my clients, because they're like, we cannot go to every single one. And I get that. But, do a payor mix, see where your main ones are, and take a look at their stuff, because you need to arm yourself with that information to make sure you either, 1, aren't getting denied, 2, aren't getting paid stuff that you're going to have to give back, or leaving money on the table and not getting paid for stuff you should. So, you want to make sure you're kind of up to date on, your major health plans that are on the commercial side. But now with the ASC, an ambulatory surgery center, so they can't do anything they want there. It's set up as kind of like a same day surgery center, right?
Correct.
So
outpatient procedures.
How do they get to say, or who gets to say, what can and can't be done in an ASC?
CMS has put out a list, actually, and you can find those again on the website that I provided for the presentation.
The ASC Center one?
The ASC Center, yes, and they have addendums that they put out. And so, for example, addendum AA, hang on just a second. Sorry, Betty, I lost my
that's all right.
thing here. Addendum BB is the covered procedures that include separately billable ancillary services. So, for example, there are instances where you may be providing a service to the patient, a procedure where you get to carve out, if you will. We call it the carve out method. There may be other ancillary services that you can carve out of that procedure. So that is, you can find that in Addendum BB. And again, this is listed on the CMS website under the Ambulatory Surgery Center little area, if you will. They put out another addendum you can look at is like DD1 that gives you ASC payment indicators. So, for example, like A2 is a surgical procedure on the ASC list. The payment's based on, OPPS relative payment weight. You can look at the payment weights. There's an addendum for that. They have an addendum EE, which is these services are excluded from the payment list because unless they're extenuating circumstances, because these services are not necessarily performed in an outpatient center, if you will. And I like to use one that's as an example. For example, if you have a bone lesion or you're resecting a femur, resecting either a knee or femur tumor, that's a little bit more extensive, and that would probably be done on the inpatient side and not on an outpatient basis. The things that happen in an outpatient side are things like your colonoscopies, your endoscopies, pain management services. We see a lot of those being performed in the ASC surgical centers. Maybe your children is having their tonsils taken out, something that's, I don't want to say quick and easy, but quick and easy without a lot of complications. And you can find those in addendum AA. So all of that is, knowledge. It's out there. It's publicly, printed out there and kept in the nice little Excel spreadsheets, which is very nice. You can go in there and look up the codes. Yeah, it's really nice. Do your find search function and type in a specific CPT code, if you will, or even a device code. For example, I mentioned earlier those C codes. Type in your C code, see if it's a covered service. And speaking of those on the devices, you want to make sure, if you're responsible or working with ASCs, if you're in an ASC and you're responsible for the revenue cycle function, you want to make sure that you're appropriately including the cost of those devices into the procedure code. Add the cost into the cost of the procedure code so you get reimbursed for the total service, if you will, as well as the device. You can't break them up. If you only include your procedure, they're only going to pay you for the procedure. You won't get that extra money for the device because when you try to submit the C code separately, they're going to say it's an unbundling situation. They're either going to take the money back if they've already paid you, or they're not going to pay you if you have a current claim out there. So,
and as we know, some of those devices get pretty pricey. So you definitely want to make sure you're getting reimbursed for that stuff.
Yes. And I see a good question that it says, are these addendas updated year after year? Yes, they try to do the updates yearly. I believe this last update on this one was 2022, not necessarily yearly, but that's the closest update for the list. And they also put out an inpatient procedure list as well. And there's a little section where you can actually go in and look at the ASC conversion factor as well, if you want to look at that. Now that, of course, they have to do, updates yearly because they have to put the appropriate weights to them.
Now, with a carve out, when you can get paid for device separately, is there a set fee? Like how they do average wholesale price and all that kind of stuff for drugs? Is there like a set fee that they will pay you, or are you paid for what you pay for that device?
You are paid for the cost of the device.
Yes. Okay. So it's not like you can make money off of those if you get a cheaper one, or you lose money if you. So it is a straight payback. That's good. That's good. Okay.
Yes. And one other thing I found interesting as well, if you dig into the rules, and regulations, again, we talked about, it being like a stopgap between a provider office and a hospital. And there's some discussion between the entities, if you will, on the technical time, if you will. And they're saying, if you're in an ASC, and any of you that have ever had a procedure in an ASC, depending on what type of procedure you have, at least in my area, it's like they want you in and out. I mean, they're like getting you out of the bed before you're even out of recovery, if you will, and you're still, drugged up from the anesthesia, and they're putting your clothes on and shipping you out. But the rule is you cannot be in an ASC exceeding 24 hours. Some guidance say not to exceed 24 hours, and some guidance will actually say 23 hours and 59 minutes. So It's like, come on. So yeah. So just be wary of that too. It's time specific. Other guidance says, more than 8 hours, less than 24 hours. So yeah.
Great. Now with the, Lady has joined us. Hey, Lady.
Hey.
With the ASCs, we have to look on the list, see what can and can't be done in the ASC. And then from a billing standpoint, I know I have one client, they were saying that, when I was reading on something, that sometimes some of the ASCs use UBs, some of them use the 1500, so billing requirements sometimes can change on a state by state basis too, right?
That's correct. The normal procedure, if you will, again, it all depends on your state, your MAC, your private payer requirements. That is also one of the other little nuances with ASCs is normally they would bill out the services on a CMS 1500.
Okay.
So it just, again, you need to make sure that you're following, your specific locality payment guidelines.
And then then they're looking for the tax ID, or they're looking for, to notate the fact that it's the facility actually billing, even though it's on the 1500 versus the professional side of the
Versus
service.
the professional. That's correct.
Okay.
And another big myth, and I like to say a myth, if you will, I've always heard, as well that, oh, well, we just mimic what the provider bills. And again, sometimes, yeah, it may be the same thing, but sometimes it could be a little bit different for the facility side. So always make sure, you're following the guidelines and you're reading those reports. If you're a coder biller, make sure that you're really digging into the rules and regulations and choosing those correct services based off of the op note. Just don't, go by the physician handing you a slip and say, no, this is what I billed today. Don't get in that bad habit.
Well, is it because in some cases, I don't know if this is true or not, I have limited ASC exposure, which is the reason why I wanted you to come on here. On the pro fee side, we've got the bundling rules and things like that with coding, which may not be the same bundling that you have with the ASC. So that's another thing too, right? Just because they're saying here, this is it, and they only write the one thing because for them, that's what they bill. But that doesn't mean that for the ASC, that's all they're going to get able to report, right?
Correct. Because remember, there may be some procedures where, for example, the physician does a certain procedure and that's his CPT code. But remember, on the ASC side, that may be a carve-out procedure. So they may have, additional labs. They may have some, x-rays or other technical things that they can bill separately for. So it's really important, that you're paying attention to those codes again and reading those, because you may get extra payment, if you will, for those carved out pieces. And that's money you could potentially be, leaving on the table.
Yeah, and I think that is sometimes an issue that I see with ASCs, is that it got to at one point to be like the hot thing, right? Was so that you'd see groups getting together and buying their own ASC, and investing things coming in and buying ASCs because they thought this was going to be a real good cash cow, thing to get into. And then they start running them and have no idea as far as billing and what they can and can't code and shouldn't do. And so they started to come into a lot of issues with ASCs when you get into them, that you have to have somebody just like an FQHC. They have all those special regulations and requirements that not that a professional coder couldn't, that works on the practice side, can't also do the ASC stuff, but it is really different, and they have to take a bunch of different stuff into consideration. It's not just a 1-for-1 as you go back and forth to look. So you got to be really careful with them to make sure that, like we've said multiple times already, just in the past 40 minutes, that you can get paid for anything, but that's really not the issue. You don't know what you're leaving on the table. You don't know what you're getting paid. You're going to have to pay back then. And those things can just kind of out of nowhere surprise you. They'll kind of let it go. And then all of a sudden it's been 2 years now. And now you're getting a letter saying, hey, you shouldn't have been doing this for 2 years. You've been overpaid. Now we want, $1 million back.
Exactly.
So it's really something that, you have to take that time. If ASC stuff interests you, really take the time to kind of dig into it, because it's not the same as working in a practice or working in an outpatient facility even, or working obviously in the inpatient side for the hospital. Because I know too that some payors and in some states, they may want them to use the PCS codes. And, so that's another different thing. It's like, how are you coding it? Are you using CPT? Are you using, you've got the DRGs in the hospitals, on that side, but some of them are looking for the ICD-10 PCS codes, which on the pro-fee side of it, a lot of coders just are not familiar at all with how to pick up ICD-10 PCS. Which I think is very logical. I love PCFs. I want to do a broadcast on that. But it's a hard learning curve coming from, volume 3 of ICD-9, into ICD-10 PCS. And it's not like CPT. It's kind of sort of like it, but it's very different. And so there's all of those considerations too, to look at if you're interested in doing ASCs. I mean, if you're looking for something new, you're looking for something challenging that's like way different than what you did, this might be an area that you'd be interested in. But I think you really have to have the kind of person that would be good at this would definitely be one of those attention to detail, but multifaceted, changing people that I like it black and white. I like what I like, and I like it to this is not going to be a good area, I don't think, for you.
Exactly. Definitely. And as I had stated earlier, for those of you interested in looking at these addendas, if you will, and seeing what's on there, and I had mentioned earlier that they don't always necessarily update the addenda AA every year to, give you clue as to what kind of services are now being performed in the ASC and what services are hospital inpatient only. They do, however, we talked, I mentioned earlier about the conversion factor, and they do update that yearly, but they actually put out a payment rule the same way, for the, like they do the fee for service side. They put out the hospital outpatient department each July for comments. And then the final rule again comes out in November, just like everything else. But if you're, interested in reading anything and everything about the ASA rules and how they come up with the payment rates and, figure the conversion factor, it's a good, interesting read.
Yeah. Yeah. But yeah, there's always places. I think the government, in my opinion, is probably the best place to get the ASC. I mean, they have the volume wise, if you're looking for getting the solid information, that's a great resource to be using. And Lady was nice enough to put a couple links in here for us for different things from CMS with transmittals and updates for the ASC stuff from January 2024. So thanks, Lady. I appreciate that. So something else to just kind of go and check for with things. And she also made a comment about modifiers. And that's another thing, on the ASC side, that they do use some different modifiers than we might use on the physician pro fee side. So, which is another reason why you can't say, oh, we just take what the physicians did and we just put it over here, because they do use some modifiers that we don't use on the physician side, like modifier 73 and 74. And those the anesthesia ones where they stop the procedures?
Yeah, 73 is for procedure discontinued after prepping, or while prepping, if you will, and then 74 is for discontinued after anesthesia has been introduced or administered.
Okay. Yeah, because again, remember the bills and the claims that are going out are to get the ASC paid, not
Correct,
the physician.
not the physician.
You know,
and two other ones that are kind of, a loan, if you will, specifically for the ASCs too. Again, we talked about making sure you're reading those rules and regulations and making sure your devices, are included and all that. But they also use a modifier FB, as in boy, for devices that are furnished at no cost or full credit, if you're given credit for that. And FC, as in cat, for devices furnished at partial credit. So those are important too, to make sure you're paying attention to on your devices and how you're paying for your devices and whether you're including those, full price into the procedure code, or if you've been given a, discount or something, to make sure you're, appropriately reporting the correct amount.
okay. Well, yeah, because again, it's all, what do you have an idea? I don't, and if you don't, that's okay. What kind of margins, these ASCs are, running on? Or do they have like really big margins that, they can afford to not get every procedure or be missing some stuff and still be okay? Or are we talking like super tight margins?
I just know, in generalized, for what I've been working with in here lately, is, they're very small ASCs that might just be a one-off. They're not attached to any big systems, if you will. And, so they are very tight margin. I mean, if they continuously would, for example, I keep using that pacemaker, example, but, if they would unbundle and continuously charge for the device as well, and have money paid back, it could literally be so detrimental to them. They could potentially lose the business because they are running those tight margins. Now, ASCs that are, owned by huge healthcare systems, they might have a little bit more leeway because they could, pull resources, if you will, monetary resources from one to the other to help cover. But you got to be real careful. These mom and pops, if you will, ASCs, it's tough if they're doing not the right thing, and, they have to pay back, especially if it becomes a problem and, the government looks at it as a problem, and then they could potentially have, fines and fees, etc., on top of that. So it's really important.
Yeah. We got a couple questions. Let's see what we can get to in our, and Jeanette is joining. Hey, Jeanette, and Ladriba has joined in. Hey, Ladriba, good to see y'all. Where did it go? There was a question about PQRS. Catherine asked, I saw it, but I can't find it now. So she was asking about PQRS, reporting that in the ASC center. Now, to my knowledge, the ASC itself wouldn't be reporting PQRS.
Correct. They don't report those. That's correct. They don't have to report the quality measures at this time. Yeah.
Well, yeah, we could always say that right now.
Yeah. And then I saw a good question about the anesthesia. Somebody asked if anesthesia was separately billable.
Yeah.
So anesthesia do you still have
to bill for an anesthesia separately from the outpatient, or on the same?
Yes. In the ASC side, services that are include the anesthesia. So it would not be separately billable.
Okay.
Yeah.
Are there things that are always separate?
I'll give you what's got some things that are included, and then what is like carved out, if you will. So, for example, in the ASC payment system, you're getting, paid for your nursing services, if you will, any nursing, any technical services, the facility surgical procedure you're being paid for, any drugs and or biologicals that are not separately carved out, payable by the outpatient prospective payment system, that would be separately paid. If it's, an orthopedic situation, any castings, the supplies, any surgical dressings, for example, any appliances, those are included as well. Any diagnostics or therapeutic services that are not, specifically carved out, those would be included. Any anesthetic that's administered and or monitoring, the supplies and or equipment, you can't bill separately for that. Any implantable prosthetic devices, those are included, unless again, they're, considered a carve out. Any packaged radiology services. And also to note if they're a big, huge group or whatever, and the anesthesiologist is monitoring any nurse anesthetist, I can never say that word, their services are also included. That's not paid separately. So you need to watch for that as well.
CRNAs are bundled?
The supervision services for the provider are bundled. Yeah. So the CRNA could potentially bill separately. It's just that the provider's providing this supervision services, his services are included in that facility fee.
Oh, gotcha.
So things that could potentially be paid separately are any of those ops, drugs, or biologicals, that are carved out. The carved out radiology services or diagnostic services. Any brachytherapy services, if you have those are separately payable. There's certain pass-through implantable items that are potentially paid separately. If you are doing any, ophthalmology services, the corneal tissue acquisition services, those are separately carved out and separately payable. So it just depends. There are certain instances where, yes, you do get separate payments. So it's important to know what those are and apply them correctly to, your billing habits.
And looking at the links, the references that we've given before, that's where you're going to have these listings and those addendum. Is that correct?
Correct.
Okay. So it's important if you are interested in ASCs or are in an ASC as maybe a newbie, coming in there that is like, oh, hey, we've all been there, right? And like, oh, well, coding here, just irregardless of specialty or that it's like totally different criteria where things are just kind of handed over and you're told, oh, you do this. This just should be easy. That's a good place to go look through those addenda to get all of that information to look at what you're doing. Is that a good, am I on the right track with that?
Yes, you are on the right track.
Is there any other reference that you could think of that people, other than the CMS, is there like another company that you know of that's kind of good at helping people with the ASC stuff?
There's an association for ambulatory surgical centers. You can, check out their website if you're interested. They provide, a lot of good education as well, put out documents and articles and little tidbits here and there. So that's another good resource to check out.
Good. And what is just the association for?
I think it's, and I'm sorry, Betty, I should have included that.
Okay. But I think just thought of it.
I think it's ASCE.com. I'll make sure I provide that. I don't want to talk out of turn.
Oh, okay. Well, we'll put that in.
Yeah.
We'll put that in the replay. We'll have that added in, that link added in later for everybody if you want to come back and look at it. But I think it's always a good idea sometimes when you have associations, especially good ones, or societies, to be able to go and reference their things, because sometimes you can get a different view of what CMS has said or what, something that's out, or maybe there's some groundswell of where they're putting out opposition to something that, maybe you're struggling with. And the association or the society is like, yes, we're on to it and we're writing letters to CMS and doing, so where you can see that there's some activity going on about things. So I think it's good also to have something like that, a place like that, to kind of fall back to and to look at. And a lot of times, like the AAD, the American Academy of Dermatology, they're one of the associations for the dermatologists that they can go to and look for those kinds of things and different information and stuff. So I think it's good. I see lady, is it the ASC Association?
Yeah,
Is this
and
it?
I just posted that in your
Oh,
little thing. I don't know if you
wonderful.
can
Thanks.
see it, but yes.
Good,
Thanks, lady.
good. I know it's always good when we've got people on here when they're kind of flipping through stuff to help us out too. So I appreciate that, lady.
And they have really good resources. Like I said, they have, they put out publications, especially if you're in the, helping somebody in the process of setting up, in the beginning stages, setting up their ASC. That gives good guidance, start good with a good foundation and build from there. They have financial publications out there to help you, monitor and set up their billing systems. So it's a really good tool.
Good. Well, good. We are, believe it or not, coming to our hour time already. So for people that want to contact Shelly, I want to make sure I had time in here. Shelly's on LinkedIn. So here's her LinkedIn profile. And again, I'll paste it into the comments so y'all can go ahead and see it. And then her company, which is Kennedy Neghan Healthcare Resources. Now, did I say their names right?
You did.
And I think that's so cute. Tell everybody how you got the name of your company, because I love that.
So naming the company, of course, you always want it to, at least for me, I want it to be meaningful and special and, kind of fit my personality or situation. So Kennedy Neghan is based on my granddaughter's middle name is Kennedy and my grandson's middle name is Neghan. So, and how he got his middle name Neghan, my daughter and I used to be, or still are, if you will, it's no longer on the TV, but big Walking Dead fans. So, and we got to meet Neghan, the guy, Jeffrey Dean Morgan, who played Neghan when my daughter was pregnant. So he was unfortunate maybe for him, but we named him Neghan after that character. So Kennedy Neghan is based on the names of my grandchildren.
That's nice. And then also Shelly's email, you can reach out to Shelly on Gmail at kennedynegan@gmail.com. So different ways that you can get a hold of Shelly. I love that Neghan. I know you told me how you named it, but I didn't realize that he got his name from The Walking Dead. I have not watched that for a little while now after Rick. I was just like, okay. Well, actually, when his son, that's when I first started going, oh, I don't think I'm going to like this now. But Neghan was always such a nasty little guy. So
my grandson's sweet. So
I was going to say, I hope your grandson doesn't follow his personality, though.
Yeah.
But thanks for joining us today. And thanks to everybody for joining us on the program for this hour to talk about ASCs. And just to let everybody know, in 2 weeks, Sonal and I will be back together to do our quarterly E&M question and answer. So if y'all have some E&M questions, make sure that you are sending them in to me or Sonal before we have that, so we can kind of line up some answers and some resources maybe for y'all. Shelly, are you going to be, and I just ask people that come on just in case, are you going to be anywhere speaking or doing anything in the near future that you would like to kind of put out there for people?
I have some speaking engagements in the works, but they're not finalized as of yet. So I'll definitely, when they are finalized, I'll put them up on my website for anybody that's interested, because they're always, you're able to attend if you'd like. So, the more the merrier. I enjoy it.
Wonderful. So just for those of y'all that are on today, make sure you connect or follow Shelly on LinkedIn so that you get notices when those things are going on. But everybody, make sure that you enjoy the rest of your day. And we're closing in on the weekend. Tomorrow's Friday. So everybody enjoy the weekend. And thanks again, Shelly. I was very
Thank
happy to
you.
have you on today.